Good afternoon. My name is Sam Behjati. I'm a group leader at the Wellcome Sanger Institute and an honorary consultant pediatric oncologist at Addenbrooke in Cambridge. Thank you so much for giving me the opportunity today to speak to you about genome sequencing. My lecture is entitled How Genome Sequencing Might Help My Child, and this is about the sort of new ways of looking at tumors that are about and available to you. As I said, I'm based at the Sanger, which is the birthplace of the Human Genome Project, located south of Cambridge. I also work as a clinician at Addenbrooke in Cambridge, and I'm a fellow here in one of the Cambridge colleges. What I would like to talk to you today about is how genome sequencing is related to childhood cancer, how it might help children diagnosed with cancer, perhaps why you might not want to get this done, and then finally some practical thoughts on how you can get whole genome sequencing data for your child. The context is this. So you may or may not remember that a few years ago, David Cameron launched a project called the 100,000 Genome Project that had the aim of generating vast amounts of data from individuals with a variety of diseases presenting to the NHS in England. And as part of that, there was a component that was targeting children with cancer, enabling clinicians to generate this genome data for their patients. That project stopped a couple of years ago. And now components of that project have been adopted by the NHS as a routine clinical test. The organizations that does it, organization that does this is called Genomics England. And Genomics England is now offering very uniquely to children with any kind of cancer, be it a leukemia or solid lump, that they can get this tumor whole genome sequence. And that's what I want to talk to you about today. So first and foremost, I would like to explain how genome sequencing is related to childhood cancer and therefore why you might want to get this done. So we often say that cancer is a disease of the genome, and what we mean by genome really is our genetic code. So we all have a unique genetic code, and that code tells the body who we are, how we function, and so forth. And every cell in our body carries that genetic code. That genetic code is very, very, very long. So what I'm showing you here is a picture from the Wellcome collection in London. They have actually written down the genetic code in books. And basically you need 109 very large books, 23 volumes thereof, one for each chromosome, to write down all the 3 billion letters that make up our genetic code. So that's really quite incredible. Every cell that we have in our body has a copy of our genetic code of those 3 billion letters. Cancer happens when there is a change in the genetic code or a mutation that hits important pieces of information. And what I mean by that is the following. So imagine our genetic code, about 1% of it has got a building instruction, a manual of how to make little machines called genes. And the genes are the machines of the cell. They make us work, they make us grow, they make us live. They make our muscles contract, they make us think, and all of those functions. There are lots and lots of little machines, about 20,000 of them. And imagine this, pretty old beetle is one of those machines. What can happen is that the instruction, the letter code that encodes the building of this beetle gets an error in it. And I've symbolize these errors with these blue marks. Now, most of the time, these errors are completely unimportant. Whether or not this beetle has a few stains on it is completely unimportant for its function. It'll drive, it'll just be fine. And at the end of the day, it is still a beetle. no matter how much dirt it accumulates on its surface. However, very, 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 very occasionally, the error in that genetic code that tells the body how to make this beetle has got an important error. And that error then changes this beetle into something quite different. And I've symbolized this here with this machine gun. So rather than now just being a cute little beetle car that's driving around, now suddenly this beetle has a machine gun, and this is what the mutation achieved. Most of the time, mutations don't matter. They just do either nothing or they're just a little stain, but very occasionally they turn a gene into something quite nasty, and that is the substrate for cancers to grow. So cancer happens when mutations in our genetic code hit important pieces of information. Now, the question, of course, you might raise is, where do these mutations come from? And they just happen as cells divide. So each time a cell divides, the cell has to copy all 3 billion letters. And you can imagine that, as wonderful as Mother Nature is, invariably there will be little errors introduced. There are actually very, very few errors. So we reckon with each cell division, perhaps 1 letter is copied in the wrong way. Now, the other source of mutations are naughty habits such as smoking or aging. And this is why adult cancer is so very common. And this is why, thankfully, childhood cancer is rare. So just to say this again, every cancer is caused by mutations. And therefore, if we know what the mutations are that cause cancer, we will understand cancer. And this is where the magic of whole genome sequencing comes in. It all goes back to this here. So a few years ago, so around after the Human Genome Project was finished, after the year 2000, people started systematically looking at genes in cancer. And the idea was, well, if we find mutations that are specific to cancer, that cause the cancer, and they're specific to the cancer, they will be present in a cancer cell, but they won't be present in a normal cell. So that gives us an opportunity for 2 things. First of all, we can identify cancer cells by virtue of that mutation. And secondly, because that mutation is unique to the cancer cell, maybe we can develop a drug that very specifically interferes with that mutation. So if you think about that beetle with a machine gun, maybe we can find a drug that very specifically goes and only kills beetles that carry a machine gun. Of course, those are the cancerous ones, and the normal beetles without a machine gun would be unaffected. And the paradigm for this was the discovery of a particular mutation in a gene called BRAF in malignant melanoma, in metastatic malignant melanoma, which up to then was a universally fatal disease. And then people went on and developed a drug for this mutation. What I'm showing you here on the left is this PET scan here, and you can see that there are lots and lots of black dots representing metastatic disease. And then this individual was given a drug that very specifically targeted the mutation. And lo and behold, this man had a quite wonderful response. And you can see that all the malignant melanoma black dots have disappeared on the right, and the only black bits that you see are the bits that would always be, normally black on a PET scan, such as the brain, the kidney, and the bladder. So this was really a profound moment in the history of cancer research. The only issue is, unfortunately, that response doesn't last, because melanomas are very clever, and what they do is they just develop another mutation that then renders them resistant to this. But as a principle, it sort of highlighted that it's really important to understand mutations, and we might be able to use them to treat individuals with cancer. Now, so how might it help children diagnosed with cancer in the real world? The potential benefits above standard of care, and that's a really important sentence to add. In pediatric oncology, we are very, very advanced in terms of what tests we do on tumors to make a diagnosis. And quite often we already look for mutations without necessarily reading all 3 billion letters. So the potential benefit above standard of care may be to provide a diagnosis that may help us make a more informed decision about how nasty or not a cancer is. It may add a treatment option, and it may tell us whether a child was predisposed to getting a cancer. So most of the time, cancer in children just is randomly happens out of the blue, but very, very, very occasionally, children are born in their genetic code with a predisposition to developing cancer, and doing whole genome sequencing might help us identify those mutations. So what I will do now is, just to make this a bit more plausible, is just talk through a few examples of our experience in Cambridge. So we participated also in the 100,000 Genome Project, and I will just give you an overview of what we think we learned in real life in the NHS in England in the 21st century. So we, as part of the 100,000 Genome Project, there were about 200-300 children enrolled who had cancer, and Cambridge contributed 1/6 of the national cohort. I'll show you some data on brain tumors and non-brain solid lumps, including lymphoma. However, this program also applies to children with leukemia. I'll talk about in what way we found it useful. And this is based on real life MDT discussions. But at that time, we didn't use the results in real time, whereas now, with a new program that is no longer a pilot thing, it's a real life test available to clinicians. Of course, we do use the results in our clinical practice. So the potential benefits above standard of care for us have been as follows. So in our 36 children, in 4, it helped us to make a diagnosis. In 8 children, it helped us to refine the prognosis. In 7 children, it added treatment options. And in two children, it identified cancer predispositions. I will talk you through a few examples so you get a sense of what it's like. So first of all, talking about diagnoses. So this was a young lad who presented to us with this renal tumor here. So this is an MRI scan. It's a cross section, sort of a section through the body in the middle turned around. So you're looking here on the right-hand side, you can see the liver, the kidney, in the middle, the spine, and on the left, the spleen. And then there's this big tumor here in the kidney, and we took a biopsy, and lots and lots of pathologists locally, nationally, and internationally looked at this, but actually could not tell us what kind of cancer this was. The people felt that the most likely diagnosis was an adult type cancer arising in a child. And when we did whole genome sequencing, what the whole genome sequencing actually showed is that although the tumor looked very, 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 very odd under the microscope, it had all the classical mutations of a Wundt's tumor. Wundt's tumor is the most common childhood cancer. We know very well how to treat Wundt's tumor. The child, because there was a lack of clarity as to what they had been treated as a pediatric patient anyway, so we treated them on a childhood renal tumor protocol. They've done very well indeed. What this case highlights is that sometimes when a pair of eyes in classical tests of sort of conventional pathology fail, it will be really helpful to do whole genome sequencing. Here we were able to yield a diagnosis, which is really, really very important in order to get everything right thereafter. Here's another example of a baby who had a brain tumor. They were diagnosed with a pilocytic astrocytoma. Pilocytic astrocytoma is a low-grade brain tumor. They normally have a classical mutation that we look for by normal testing. However, this particular pilocytic astrocytoma did not have that mutation, which raised a little bit of a question mark as to whether it really is a pilocytic astrocytoma. And we did whole genome sequencing, and it gave this tumor a completely different label. In terms of treating this child, it makes no difference. But again, it's very important to have the label correct to be then able to say how likely it is to progress, what one might do. And the other important is this particular very long-winded label of infantile hemispheric tumor with ALK alteration, what's so important about it is that this ALK alteration is something which we could target potentially with a drug. So I'm now going to give you some examples of where it has helped us with getting the prognosis right. So the most instructive case was this child here who had what we call an undifferentiated sarcoma. So what that really means is that under the microscope, it looks like a sarcoma, but with all the tests that we have available to us, we can't give it a better name than this is a sarcoma, which is why it's called an undifferentiated sarcoma. They have a very, very poor outlook. When we did whole genome sequencing, what this showed is that actually we can give it a very specific name. It carries this mutation, which is called a B-core-CCNB3 fusion, so mouthful, doesn't really matter what it's called, but we can now give it a name. And the other very good thing is we actually know quite a bit about this kind of sarcoma, and we can say to the child, to the family, well, actually, this has got a much better prognosis than what we initially thought this tumor would have. And that, of course, is so very important to know because it helps planning, it helps everything else. And we need to get these information right, of course. So the holy grail of doing all this is to add treatment options. And in our experience, in 7 out of 36 children, we were able to add a treatment option, but I just want to caveat this a little bit. So no matter what diagnosis a child has, we almost always have a plan A in place already that we know works either reasonably well, or at least we know that it does work. And therefore, it would be very unlikely that we would ever substitute standard of care treatment with a fancy kind of treatment where we try to target a mutation. So that is almost always true. So there's almost always a conventional plan A that may be chemotherapy, surgery, radiotherapy alone or in combination. And we would always pursue that plan A because it would not be ethical to start experimenting on individual children when we have got very good treatment, no matter how awful the side effects are. However, very, very occasionally, we do not have a plan. And then it's very useful to know the mutations because one might be able to target them. And the second thing I'm going to say, even though we may not use the mutations and we may never, thankfully, may never have to use them because plan A works well, I personally find it as an oncologist really very helpful to have my plan B in place before I need it. So this is a really, really important disclaimer. And this idea of adding treatment options and actually using them may be more relevant in adult cancer than it is in pediatric cancer. So in 7 out of 36 cases, in our experience, we were able to add treatment options. And those were either specific mutations for which we know there are drugs that we can use to target the mutation, or certain patterns in how the whole genome looked, the genome of that particular cancer that revealed specific sort of treatment opportunities. And I mentioned this baby before with a brain tumor where this ALK alteration, ALK is a gene, ALK alteration is just another way of saying an ALK mutation. We know that if we had to intervene beyond surgery, that there might be an opportunity here to get a drug to target ALK. The other thing that I should add is that getting these drugs for specific mutations is sometimes practically not feasible because they may not be licensed in children or are not available in the UK, but your oncologist obviously will move heaven and earth to make it happen should it be required. And then the final thing that whole genome sequencing does offer is to reveal whether a child has got a predisposition to developing cancer. And that is both a benefit, but one could also look at it as a big downside of whole genome sequencing. And this really brings me back to the next point. And I want to stress this over and over again, that there might be a reason why you as a family choose not to have whole genome sequencing data. So some may look at knowing that their child has got a cancer predisposition as something useful to know, because it may help the child in terms of thinking about how we treat them or how we screen them in the future. And it may help then to perhaps screen siblings or parents, aunties, cousins, and so forth. But others may look at this and say, well, actually, I think this is something really I don't want to know for myself, for my child. And actually, it's not something that I would want to pursue. And it's really important that this is beyond good and evil. It's neither right or wrong. It's just how you as a family feel about it. And that's all that matters. There's no judgment about it. But you need to be aware of that this is one of the big caveats of whole genome sequencing. I will give you a couple of real life examples, so it perhaps makes it more understandable what I'm trying to say. So in our experience, we had this one child who had a cancer. I won't go into too much detail, and whole genome sequencing revealed that this child in their germline, so in their body, in every cell in their body, carries a mutation, in fact, 2 mutations that predisposes the child to having cancer, because those mutations, they impair how the body repairs errors in DNA. So when the cells divide, remember I said to you, we sort of acquire 1 error with each cell division. In this particular child, many more errors per cell division will be acquired, and therefore the chances of getting a cancer rise exponentially. Now, these mutations explain their cancer, and they helped us because children who have got that particular mutation, there is a particular, or this particular mutation in the germline, this mutation making error, we have got a specific treatment that we can target to cancers that are made in that way, that are generated in that way. So that's a very good thing. Now, the bad thing, of course, one might say is, well, so we now know that this child is predisposed to having cancer in the future. That could be a very good thing if you look at it from the point of view, well, we can now screen the child and be proactive about it, but others may actually say, this is not enough, something we wouldn't want. And of course, sometimes these mutations come out as a blue, but quite often they're inherited from parents. And in this particular case, each parent carried 1 mutation. So now the parents are also at risk of having cancer at a younger age. And then one could consider the wider family. So just this, I think, beautifully perhaps illustrates the complexity of it. And it's not a black or white thing where it is absolutely right or absolutely wrong. It's a very personal, a very private decision that you will have to make, and it is okay. You know, there's no judgment associated with it. It just is what it is, what works for you. I'll give you another example. So another child with a cancer, and whole genome sequencing identified that this child carries in their body a mutation that predisposes them to having breast cancer at an early age. And that mutation probably is not related to their childhood cancer. Now, the benefit for the child is going forward, you know, thinking 10, 20, 30, 40 years down the line, I will be able to recommend to them and their GP to start breast cancer screening very early. And for me right now, as their oncologist, it helps me thinking very carefully about giving radiotherapy to the chest in this context. However, it of course also has implications for the child's mother. And if she carries the mutation, it would have an implication for her sisters, for her mother, for her grandmother, for the aunties, for the cousins, for the siblings. So again, it's an example where, on the one hand, one could argue it's really useful knowledge and important knowledge to have. On the other hand, it is off target in that it has nothing to do with this child's cancer now, and maybe that is something that you might not want to know. So these are very complex considerations. So the one thing that I wanted to get across to you today, and this is why I have labored this point a little bit, if you feel a little nervous about this, then so when if you wanted to go down this route and you had your consenting discussion with your oncologist, they will bring up all these things again. And if you then think, well, actually, this makes me a little bit nervous, then don't feel bad about it. There's no obligation to, of course, say yes. And also, it's completely judgment-free. But make sure you spend quite a bit of time thinking about it, speaking to your doctors. Maybe you want to speak to a geneticist to understand the implications in some detail. So the last thing then I want to say, how can you actually get access to it? So just to go back again, so the 100,000 Genome Project is done. Towards the end of 2020 in England, NHS England has started rolling out to offer whole genome sequencing to every child diagnosed with a cancer in England. And, for the NHS to say, now, just start doing it to actually happening, it takes a little while because pathways have to be put in place, and the program has to be rolled out in individual units. But in principle, it should be available to all children diagnosed with cancer in England. As far as I know, this is not available to children in Scotland and Northern Ireland, and I don't think it's available in Wales either. Having said all that, of course, within the United Kingdom, children can be referred around, from one center to the other. So one might be able, and I haven't thought this through in any great length, one might be able to indirectly achieve it even outside England. Sometimes whole genome sequencing is technically not possible because the sample quality isn't very good, or the biopsy is very small, or the machines fail. This is quite sort of complex data generation. And I just want to stress, not all centers have their pathway sorted just now. And I would recommend that after I've talked about it and you find this interesting, please do speak to your hematologist and or oncologist about this. Now, just to conclude, what the NHS is doing here is world leading. So I am not aware of any other country in the world that offers whole genome sequencing. So reading all 3 billion letters of a cancer's genetic code on a routine basis. So there are some academic centers such as, I don't know, Harvard or St. Jude's that may offer it to their patients or to a sub cohort of their patients. England is the only country who will make this available to all children. That's really, truly, truly wonderful. It's really beautiful to be able to say that a child is treated in the same way, no matter where they present. However, things are still being built, sorted out. So please speak to your hematologist, oncologist about this. And as we go forward, we will learn more and more and more about how useful this may or may not be. So thank you very much for listening to my talk. I look forward to having the opportunity to discuss some of your questions that you may have in the panel discussion, and goodbye.